Hello, this is Michel Gagner. I would like to present on weight recidivism in sleeve gastrectomy, or loops. These are my disclosures. I would like to talk about this French study, which is explaining on revision surgery after sleeve gastrectomy. It's a nationwide study over 10 years, and it's interesting to see that they have analyzed over a period of 10 years, nearly 225,000 sleeve gastrectomy. The revision surgery after sleeve went from 4.7% at 5 years to 12.2% at 10 years. So we're probably going to do more of those as time goes by. A history of gastric banding was associated with a high risk of revision. And the most common revision procedure was gastric bypass in 3/4 of them, followed by re-sleeve in nearly 1/5 of them. Here's the graph of the total group over 11 years, in fact, and the breakdown between those who had previous bending versus no previous bending. As we know in France, a lot of bending patients ended up with a sleeve, and you can see that that option created more than 20% of them went for a re-operation after their sleeve, presumably because the sleeve could not be constructed as well because of the scar tissue due to the bending. So those who experience revision surgery had a higher prevalence of female sex, a body mass index more than 50, they were super obese, more common history of previous bending, as I said before, and type 2 diabetes, probably because patients insisted in having something for their type 2 diabetes. So the highlights is that you have 12.2% revision at 10 years, gastric bypass in 3/4 of them. The revision was mainly for persistence of obesity, not to, as people think, reflux was the main indication. It's not the case. Reflux was only 5% of all those cases, and they got a lot of complications. So you got to think about that. 5% gastric leak, 18% bleeding, and reoperation was 6%. And this is probably the majority in gastric bypass. So the problem with this paper, I think, which is in press, is that body mass index in more than 50, in my book, you've got to tell the patient that it's likely to be a 2-stage procedure, because sleeve gastrectomy for body mass index more than 50 is not an adequate primary procedure. A Roux-en-Y gastric bypass as a revision of sleeve, if the patient was super obese, is also not a good option, because we know that in super obese patient, Roux-en-Y gives 40% failure rates. So that was the wrong strategy in France. I believe they do the wrong strategy in doing Roux-en-Y gastric bypass in these sleeves for weight. We know that over time, the stomach tube dilates over time. We know that even after 1 year, there is a 50% increase in volume. It goes from 124 ml to 188 ml. And it's a uniform distension. The antrum and the rest grows at the same pace. And we know that as volume increases, and if the volume is increasing more rapidly, that the percentage of excess weight loss is going to go down at the same time. So that's why I insist when I do the sleeve gastrectomy to dissect the fat pad, really isolate the front and the back of this fundus and eliminate all fundus. Now, one option is the re-sleeve. I know the talk is about Roux versus loops, but this is an increasing option. Re-sleeve gastrectomy, this is a 5-year data after 52 patients. And you can see here that pre-sleeve, the body mass index was about 45. It went down to 35 post-sleeve, and then regained weight to 40 body mass index. And then a re-sleeve got them down 10 points 5 years later. And this is with other papers published in the same vein, with overall effective and durable, reaching more than 60% of excess weight loss at 5 years. It's best in patients who had an initial body mass index of less than 50. and has an acceptable complication rate. This is a systematic meta-analysis review of all the re-sleeve, and they've pulled 300 patients over a period of 10 years. The time that it elapsed, and this is in press again, and this meta-analysis between the sleeve and the re-sleeve can go up to 132 months. It took 51 minutes to complete a re-sleeve with a 2% leak rate, so higher than a sleeve gastrectomy itself, with 7.6% complication. The hospital stay was 3 days, and it gave 62% of excess weight loss in these 300 patients, so it's quite very promising. Now, most people are focused on intestinal surgery for weight regain after sleeve gastrectomy, and Dr. Torres and Sanchez Pernotte have updated. This is IMPRESS in SWORD at 5 years. They've updated their data, CD after sleeve gastrectomy, and it gives a percentage of excess weight loss overall above 75% at 5 years. If we look at the breakdown of body mass index less than 50 versus more than 50, you can see that with less than 50, it's nearly 100% excess weight loss, while those who had body mass index more than 50 did very well, but it's around 70% of excess weight loss. This is a meta-analysis of looking at all the CAD, duodenal switch, and Roux-en-Y gastric bypass after sleeve gastrectomy by the group of McMaster University. And you can see that it favors in a major way CAD and DS versus Roux-en-Y gastric bypass by at least 10% of total body weight loss difference. The length of stay was even better for that group, and adverse events were about the same, even though it looks more complicated to do a duodenal switch. Now, this is IMPRESS, an article IMPRESS in SWORD again, comparing SADI versus single anastomosis gastric bypass from the group of Germany, Recklinghausen. And you can see 42 patients in each group. At 3 years, it looks like the curve are diverging and that the SADI is doing better. This is for total body weight loss at 44% for SADI versus 40% for single anastomosis bypass. And for percentage of excess weight loss, it's 80% for SADI versus 73% for single anastomosis gastric bypass. If we look at simultaneous procedures, 23 cholecystectomy in the SADI. If we look at adverse events, there was 27% of bile reflux in single anastomosis gastric bypass versus 4.8% for SADI. Readmission were much more for single anastomosis gastric bypass versus SADI at 42% versus 23%. And there was also an equal number of diarrhea in each group, about 11.9%. Another interesting study looking at multi-center cohort study looking at single anastomosis duodenal bypass, or SADI, versus Roux-en-Y gastric bypass. And you can see that 24 months, already at 12 months, there was a difference. And at 24 months, that difference was even bigger for a total body weight loss at more than 40% for single anastomosis duodenal ileostomy versus only 25% for Roux-en-Y gastric bypass. The interesting thing is that looking at the vitamins, there was only one that was statistically different, and that is that B12 deficiencies were more frequent with Roux-en-Y gastric bypass. So in conclusion, if you have reflux, you really have to do a Roux-en-Y gastric bypass, but if you have to do this for weight loss, you're better with SADI. And my take-home message is this one: dilatation of the sleeve with an initial body mass index less than 50, and especially if the volume is more than 250 by CT scan rendering, then re-sleeve is a potential option. Regain without dilatation of the sleeve, and the body mass index was less than 50, or the patient has type 2 diabetes, then I would prefer to do a SADI. If the patient has reflux, then gastric bypass is the only option, with a caveat that 50% of them may have recurrence of their reflux after 5 years. For body mass index more than 50, then CD or DS, but less and less these days we're doing DS, and we're probably going to be doing a DS if the CD doesn't do as good weight loss, because the results are extremely well and simplified in technique. Thank you very much.